Welcome back. This is part 2 from Epidural Analgesia. In part 1, we learned some relevant anatomy. We looked at the epidural kit. We learned about physiological effect of epidural blockade, advantages, indications, contraindication, and how we assess epidural patient. In this part, we will learn how to perform the procedure, what medication to use, some special consideration about labor epidural, troubleshooting malfunctioning epidural, and we'll wrap up with some side effects and complications. So let's get started. First, before we do the epidural, there are a few things we need to look at. Routine laboratory studies are not required routinely for initiation of epidural blockade in healthy patient. This is different in labor epidural. Patient with known or suspected bleeding disorder and those receiving antithrombotic or thrombolytic therapy require assessment of baseline coagulation status or platelet count. Patient undergoing surgeries with anticipated blood loss or hemodynamic changes may require additional workup, including CBC. Now, how are we going to prepare the patient? First, the patient needs a large bore IV cannula for fluid and emergency medication. Fluid preload is not required always in surgical patient, but required for labor epidural, either a preload or co-load. ASA monitors are required for initiation and intraoperative management of epidural anesthesia. Airway equipment like ambu bag with mask, oxygen resource, oral and nasal airways, laryngoscope, handles and blade, endotracheal tube, stylet, syringe and needles should be available. Emergency medication like ephedrine, phenylephrine, epinephrine, atropine, sedative, and 20% lipid emulsion and succinylcholine. This is my suggested content for epidural cart. So this airway equipment plus this emergency medication plus local anesthetic plus the epidural kits, chlorhexidine, occlusive dressing like tegaderm, some tapes, sterile gloves and gowns, and IV cannulas and fluids. Infection control. The ASA Task Force on Infectious Complication associated with neuroaxial technique advises the following measures. First, remove jewelry on fingers and wrist. 2, use careful hand washing before gloving. 3, use caps, mask, change with each new patient encounter, and sterile gloves. The data are insufficient to support wearing a surgical gown during initiation of epidural procedure. Use chlorhexidine with alcohol for skin prep. Drape the patient under sterile condition. Cover the catheter insertion site with a sterile occlusive dressing. When chlorhexidine, which is not supplied in epidural kit, is not available, the use of povidone iodine with alcohol is preferable to povidone iodine alone. All antiseptic solutions are considered neurotoxic if they come into direct contact with the meninges. Care should be taken to keep needles and drugs in the epidural tray separate from the skin disinfectant. Okay, so let's learn about approaches to epidural space or to placing an epidural catheter. I'm gonna show you 4 different approaches. So let's start by the most common one, which is the midline approach. How are we going to do that? First, identify the desired interspace by surface anatomic landmark and palpation or with ultrasound. The needle used to anesthetize the skin can also be used as a finder needle to help identify bony landmark, particularly in obese patients. Infiltrate the skin and subcutaneous tissue with local anesthetic along the intended path of the epidural needle between adjacent spinous processes. A large skin wheel with a smaller volume of local anesthetic in the subcutaneous tissue will serve to anesthetize the skin adequately without obscuring the landmark. Insert the stylated epidural needle along the same track with the pivot-oriented cephalad. During needle insertion, the dorsum of the anesthesiologist's non-injected hand can rest on the patient's back with the thumb and index finger holding the hub of the epidural needle. A modified approach is to advance with the dominant hand firmly wrapped around the hub of the epidural needle, while the index finger and the thumb of the non-dominant hand grasp and guide the needle shaft. Placing the tip of the middle finger on the patient's back and grasping the needle wing with both thumb and forefingers is an alternative method to engage the needle. To engage the epidural needle properly, advance through the skin, subcutaneous tissue, fatty tissue, supraspinous ligament, interspinous ligament, and possibly into the ligament of flavum. At that point, the needle should sit firmly in the midline. If the needle shaft wobbles or deviates sideways, it is not properly anchored in ligament. The epidural needle can be engaged in the interspinous ligament or the ligament of flavum. After the ligaments are penetrated, it is no longer advised to change the direction of the needle tip without withdrawing the needle several centimeters or even to the skin level. Now, these are the two most common techniques used to advance the epidural needle. Here, you will see the thumb and the index finger grasping wing. And here, you will see the non-dominant hand of the patient, the non-dominant hand on the patient back with the thumb and forefinger on the needle hub. Now, which one you should use? My recommendation, if you are just starting to do this, like junior, resident, or just starting to do this, I would go with this technique. It's probably you have more control. You go, once you engage in the ligament, you go millimeter by millimeter. And this is what I suggest to my residents and fellows. When you are more senior and you have done more epidural, there is really no cutoff number to say like 50 or 100. It depends. Then you probably can go with this because it might be faster. So this is more for senior and this is more for junior, in my opinion. Then remove the stylet from the epidural needle and attach the loosely-resistant syringe with an air or saline, with or without an air bubble, firmly to the hub of the needle. Glass or low-resistant plastic LOR syringes are appropriate. Care should be taken to ensure that glass syringes are not sticky. Now, what I do to avoid that, I usually lubricate the glass syringe with some of the saline and the kit. So I open up the glass syringe and lubricate it with saline, make sure it's going smoothly, then I use it. As the needle enters the epidural space, the plunger of the LOR syringe suddenly gives. Avoid injecting the full content of syringe, particularly with loosely resistant to air if possible. For continuous epidurals, a small volume of saline can be injected into the epidural space to dilute the space, dilate the space, thereby reducing the risk of epidural vein cannulation and facilitating catheter insertion. I really like injecting some saline, especially when I'm doing labor epidurals. Know the tips of the needle at the skin. The marking of the needle at the skin represents the depth from the skin to the epidural space. Because the centimeter marking are not numbered, it may help to count the number of centimeter marking between the skin and the epidural needle hump and subtract the number from the length of the needle. For example, usually the needle length is 9 centimeters. So let's say you counted 4 marks visible. So that's 9 minus 4, and that's equal 5 centimeters. That's the distance between the skin and epidural space. Insert the catheter with the assistance of insertion device that fit into the epidural needle hub until the 15 centimeter mark is visualized entering the needle hub. Then remove the needle without dislodging the catheter. So it's a push and pull technique. The catheter should be threaded no more than 5 to 6 centimeters into the epidural space. 2 to 3 is appropriate for a short surgical procedure. To determine whether the catheter should be secured at the skin, add 2 to 6 centimeters, depending on the distance the catheter is to be threaded to the previously calculated depth to epidural space. I usually do 5, and that will give me some spare space if I want to put the catheter eventually, and we'll talk about that. A clear occlusive dressing, and that's the key, clear occlusive dressing, should be applied over the insertion site because you're going to look at this site every day to allow inspection of the catheter. The catheter should be secured to the patient back with the connector at the patient shoulder using clear tape. Has the advantage of permitting the practitioner to visualize the proximal and distal flashback window of the catheter prior to administering boluses of local anesthetic. Okay, now let's talk about the second approach, which is the Paramedian approach. The Paramedian approach offers a larger opening into the epidural space than the midline approach and is useful for patients who cannot be positioned easily or who cannot flex the spine during epidural placement. For patients with calcified ligament or spinal deformities like kyphoid scoliosis, prior lumbar surgery, and epidural technique, mostly in the thoracic area. So 3 steps. Identify the intended interspace with surface landmark, palpate, or ultrasound. Raise a skin wheel roughly 1 centimeter lateral and 1 centimeter codal to the inferior aspect of the superior spinous process. So let's assume, this is not a straight AP view, but let's assume this is a straight AP, and that's the inferior aspect of the superior spinous process. So you go 1 centimeter down and 1 centimeter lateral, and you raise a wheel here. And then the second step, the epidural needle is inserted, which is this way here, with 15 degrees off the sagittal plane, angled toward midline and cephalad tilt. The third step, so you advance that until you hit the lamina. So you hit the lamina here, then you redirect the needle, or you walk off the lamina, aiming more cephalad and more medial. If the lateral aspect of the spinous process is encountered, usually that's if like within a few centimeters, then the needle should be redirected laterally and cephalad. The feel of paramedian approach is different from the midline approach because different tissue are penetrated. The supraspinous and interspinous ligament are midline structure that are not traversed in the paramedian approach. Okay, now let's talk about another approach, Taylor approach. I'm sure many of you haven't heard about this approach. So Taylor approach is a modified paramedian approach utilizing the large L5-S1 interspace. So by far, L5-S1 interspace is the largest interspace. It is an excellent approach for hip surgery because this is a low epidural. Hip surgery or any lower extremity surgery in trauma patient cannot tolerate sitting position, or a patient with ossified ligament. So the way you do this, with the patient in the sitting or in the lateral position, a skin wheel is placed 1 centimeter medial and 1 centimeter codal to the posterior superior iliac spine. So the posterior superior iliac spine here, you go 1 centimeter down, 1 centimeter medial, and you raise the wheel here, and then that's your entry point, and then the epidural needle is inserted into this site in a medial and cephalad direction at 45 to 55 angle. As in the classic paramedian approach, the first resistance felt before entry to the epidural space is on entry in the ligamentum flavum. If the needle contact bone, that's usually the sacrum here. The needle should be walked off the bone into the ligament and then into the epidural space in progressively more medial and cephalad direction. Now, the last approach is the Codal approach. This is mostly used in pediatric for a single shot or continuous epidural catheter placement for intraoperative and postoperative analgesia. In adults, it is used usually reserved for procedure requiring blockade of the sacral and lumbar nerve, like anal and vaginal surgeries, inguinal hernia, cystoscopy, and in patient with low back pain with radiculopathy after spinal surgery, or in patient with previous spine surgery with instrumentation who you expect to have adhesion in the epidural space. So probably not a good idea to do the interlaminar midline or paramedian approach, or called interlaminar approach. Then a Codal approach is a safer approach. So the way you do this, so place the patient in a lateral or prone position with a pillow under the pelvis and hip internally rotated if prone. In the lateral position, the dependent leg is flexed slightly, while the non-dependent leg is flexed to a greater degree until the knee contacts the bed. Feel and identify the sacral hiatus. Then, which is right here. Then advance the needle at 45 tilt relative to skin surface. Then a distant pop you will feel when the needle pierces the sacrococcygeal membrane. If the dorsal aspect of the ventral plate of the sacrum is encountered, withdraw the needle slightly, decrease the angle of the insertion, and advance again. The needle angle is lowered until it is almost flat against the skin, parallel to the coronal plane. That's once you enter. After elusive resistance is encountered, so you can do this with elusive resistance also, advance the needle slightly into the caudal canal. Advancing too far may lead to dural puncture or unintended intravascular injection or epidural vein cannulation during catheter placement. If LOR is equivocal, several millimeters of saline can be injected through the caudal needle while palpating the skin over the sacrum, like here in this area, palpate the skin. If you don't feel any raise in this area, so most likely you are injecting in the epidural space. Aspirate for blood or CSF before injecting local anesthetic. An epidural catheter can be inserted through the needle and advance to the desired level. Now, should we use saline or air? Both elusive resistant to fluid or without an air, with or without air bubble and air, are recognized an acceptable technique of identifying the epidural space. However, the bubble provides a gauge of the appropriate pressure to be applied on the LOR syringe. It will compress and provide some resistance if the epidural needle tip is engaged in the ligament, but will dissipate effortlessly with only light pressure once the needle enters the epidural space. A randomized trial comparing saline to air for LOR have suggested that saline is superior. LOR to air is not recommended for epidural blood patch for sure. The way I like the bubble technique, so saline with a small bubble, that's my preferable way to go. Complication associated with loss of resistance to air. Pneumocephalus. Pneumocephalus is interestingly, it can occur even with as low as 2 ml of air if injected in the subarachnoid space. Usually the symptoms very fast, rapidly developing, severe headache immediately after an injection once the air enters the subarachnoid space. Serious neurological injuries such as hemiparesis and generalized convulsion, nausea, and vomiting can occur. Another complication associated with loss of resistance to air, increased risk of accidental dural puncture, faster onset of signs and symptoms of post-dural puncture headache, higher incidence of post-dural puncture headache, incomplete patchy block. I have seen this multiple times when I used to do loss of resistance with air. Spinal cord or nerve root compression by air, venous air embolism, subcutaneous emphysema, increased incidence of epidural vein cannulation, difficult catheter insertion. Now, obviously, the downside if you are using saline, that you can get confused with CSF leak if you are in doubt that you had a wet tap. We'll talk about this in a few slides. Should we use sitting or lateral position? So here, this is the sitting position. Position the patient separately on the bed or operating table with a buttock at the edge, as you see, near the edge of the table, near the operator. The patient leg can be supported by the table, a stool, or in labor and delivery flexed on the bed. I usually give my patient a pillow to hug, and assistant should provide support from front and instruct the patient to relax their shoulders and flex or push their lumbar spine. You can use different words like arch your back like a rainbow or mad cat position, whatever you like. Now, the lateral position, um, the here, the patient hip and shoulder are even with the edge of the bed, as you see in the picture. The head and neck are supported to remain even with the spine. Tips to attaining optimal lateral position: align the patient back with the edge of the table or bed. Align coronal plane perpendicular to floor. Flex thigh toward abdomen. Neck should be neutral or flexed. Align hip one above the other. Rest non-dependent arm on non-dependent hip. And elevate head with pillow to avoid rotation of the spine. Regardless what position you will use, most of the anesthesiologists, they use a sitting position. My advice for you and what I do, I spend a lot of time explaining to the patient the position I need. Like even I sit in front of them. I show them how they sit. I show them the mad cat position and explain to them the procedure in details and even tell them why I would like them to be in this position. And I tell them if they 50% of the success of the procedure, if not more, really depend on them. How they sit, they stand still, and so spend a lot of time explaining to your patient the position and make sure they understand why, and that will save you a lot of time when you do the procedure. Advantage of sitting position for initiation of neuroaxial blockade: easier to identify midline, particularly in obese and scoliotic patients. Most practitioners more experience in sitting position, shorter procedure time, again, depending on your experience, shorter distance from skin to epidural space, greater syphilis spread of hypoparic solution. On the other hand, advantage of lateral decubitus position for initiation of neuroaxial blockade: sedation can be used more liberally, reduce patient movement, increase patient comfort, increase patient cooperation, improve patient satisfaction, reduce catheter displacement. Now, by the way, even if I'm doing sitting position, I still wouldn't tape the catheter in a sitting position, especially in obese patient, because when they lay on their side, they tend to suck the catheter. So I always tape the catheter, especially in this population, while they are laying on their side. Decreased incidence of epidural vein cannulation, attenuation of vagal reflex, hemodynamic changes better tolerated, bedside assistance may not be required, intentional unilateral blockade for surgical procedure feasible. Troubleshooting during epidural placement. Now, this table from Nysura, and I used most of the material from the Nysura article. It's a great reference. So let's go over them. So needle floppy, needle angle laterally, that means entry of midline or missed supraspinous ligament. So what you need to do is reassess midline, redirect needle. Bone contact at 2 centimeter. That's most likely your spinous process, patient spinous process. So re-identify the interspace, place needle in caudal region of interspace. Bone contacted more than 4 centimeters, then most likely you are lateral and you are contacting the lamina, so redirect needle toward midline. Inability to advance catheter, that's most likely force loss of resistant or narrow epidural catheter, needle too close to the dural matter, or obstructed needle orifice. Fluid, so what we need to do, just give some fluid, rotate the needle pivot, maybe use softer needle catheter, advance epidural needle slightly, and that's commonly happen because what happened that you get the loss of resistance just the tip of the needle entering the epidural space, so you may need to advance like a millimeter. Advanced needle, attempt needle placement at different interspace if the above fail, withdraw needle to ligamentum flavum and re-advance. Heme in the catheter, most likely you encounter the epidural vein or needle entry to lateral, or you have an engorged epidural vein, especially in pregnant. Withdraw catheter 1 to 2 centimeter and flush with saline, perform new placement. If heme persists, consider initiating epidural procedure in the lateral position. You get warm, clear fluid return in the needle. Oops, that's probably accidental dural puncture. Intrathecal placement. So try to distinguish cerebral CSF from saline or local anesthetic. You might want to do point of care glucose test. So if it's a CSF, you will find some glucose. If it's saline, you shouldn't. If cerebrospinal fluid, then consider continuous spinal or new placement at different level. And that's a big debate there and a big topic which I'm not covering today. Pain or paresthesia on catheter insertion. Catheter advance more than 6 centimeter into epidural space. Catheter near nerve root. Withdraw the catheter to less than 6 centimeter. Or you may need to perform a new placement. Inability to palpate spinous process, obesity, severe arthritis, patient with previous back surgery. Optimize patient position. Most likely this will work. Consider midline approach for obese patient. Use longer final needle to help identify bony landmark. Consider placement in lateral position or use ultrasound. I'll have a lecture to cover the ultrasound, so keep an eye on that. Inability to flex spine, elderly, arthritis, patient with previous spinal instrumentation. Consider paramedian or lateral position or Codal approach if you have a lower extremity surgery. Curvature of spine scoliosis, use ultrasound. Okay, dural puncture epidural technique. I'm a big fan of this technique. Why? So this is a paper that was published in ANA in 2017 by Dr. Tsin. And basically, they looked, the paper examined whether the DPE, stands for dural puncture epidural, technique has been shown to improve caudal spread of analgesia compared to epidural technique without side effect observed, like what happened with a combined spinal epidural technique. So this paper tested the onset of labor analgesia. Very well done study, 120 patients randomized into 3 groups, epidural group, dural puncture epidural, and combined spinal epidural. And notice here, they gave 20 mil in the epidural space of bupivacaine and fentanyl over 5 minutes, and in the combined spinal epidural, they gave intrathecal dose of 1.7 and fentanyl 17 miles. The primary outcome was time to a numeric pain rating scale of less than 1. So what they found, and this is an illustration to show you the difference of the technique. So what they found that no significant difference in time to pain score less than 1 between dural puncture epidural and epidural, the classic epidural. However, the mean time and interquintile to reach pain score less than 1 were 2 minutes on the combined spinal epidural, 13 minutes on the dural puncture epidural, and 18 minutes on the classic epidural. So that difference did not achieve statistical significance, but there is a difference clearly, and it's a clinically meaningful difference. So probably if they have more patients, they would find a statistically significant difference. However, what's important here, if you look at the need for patient top-up, so which means like you didn't have enough analgesia, so you need to give more medication. So the lowest was with the dural puncture epidural. What's even interesting, that greater incidence of bilateral S1 blockade with the dural puncture epidural than epidural classic epidural. There is a significantly lower incidence of asymptomatic blockade, asymmetric blockade after 30 minutes, and significantly less physician top-up intervention, and fewer side effects like itching than combined spinal epidural. So I'm a big fan of this technique, especially like let's say you are doing labor epidural, the patient close to stage 2, you really want a quick, strong analgesia, then I would go with the combined spinal epidural. But if the patient is not yet there, or you are doing like for a surgical patient, the dural puncture epidural might be a better choice than classic epidural. And you either can use the regular kit and just borrow a spinal needle, 25 gauge, 5-inch, and stick that through the Tuhi needle, or you can use the combined spinal epidural kit and use the needle just to do the dural puncture. Okay, now we place the epidural. What we should give, what we should do. First, test dose. Always we should start with a test dose. Before administering medication through the epidural catheter, subarachnoid, intravascular, and subedural placement should be ruled out. How are we going to do that? We should give a test dose. The classic test dose is 3 ml of 1.5 lidocaine with 15 mic of epinephrine. The intrathecal injection of 45 milligram of lidocaine, you know how we get that, should produce a significant motor nerve blockade if the catheter is in the subarachnoid space, right? Although recent evidence suggests that this is not always reliable, the other thing, a change in heart rate of 20% or greater within 1 minute suggests that the catheter has been placed in a vessel and should be replaced. If the heart rate does not increase by 20% or greater, or if a significant motor nerve block does not develop within 5 minutes, the test dose is considered negative. Now, I had at least one patient that I put the catheter, I suction, withdraw, there is no blood coming. So you would think, okay, so it's a perfect spot. After I give the test dose. I have a patient developed significant tachycardia. I was questioning myself. There is no way I didn't get any blood, so I give it another time. And again, the same thing. So my point here that don't rely just on suction, like in your section, there is no blood, and you think, oh, okay, that's not an intravascular. You still can be in a vessel without getting a blood back. Especially we are talking about veins that may collapse when you suction, right? The safety and efficacy of the traditional test dose is debated in the literature. In laboring patient, a change in heart rate attributed to the epinephrine may in fact be due to a painful contraction contributing to a false positive interpretation. Alternatively, a true positive test result in this patient population can result in an epinephrine-induced decrease in uterine blood flow. Patients with hypertension, including women with preeclampsia, can experience a severe increase in blood pressure that may not be well tolerated after an intravenous dose of 15 micrograms of ephedrine. I added this to just show you that there is some discussion and controversy about that. However, I still strongly recommend it to use this dose in all patients. Although rare, catheter migration may be occurred after initial confirmation that the catheter is in the epidural space. So after before each bolus, you should confirm that by suctioning that the catheter is still in a proper position, proper location. Now we did that. What are we going to do next? So dosing regimen. Local anesthetic concentration determine the density of the nerve block. So the concentration determines the density, while volume of local anesthetic determines the spread. As a general guideline, the initial loading dose can be determined as follows: 1 to 2 ml of local anesthetic per segment to be blocked in the lumbar epidural, 0.7 per segment for thoracic epidural, and 3 ml per segment of caudal epidural. So, and that makes perfect sense, right? Because you have a smaller space in the thoracic than the lumbar. The loading dose should be administered through the catheter in 3 to 5 ml incremental doses every 3 to 5 minutes, permitting time to assess the patient's response to dosing and to avoid systemic toxicity. Higher concentration local anesthetic are required for surgical anesthesia, up to 20 ml of 2% lidocaine, with or without epi, 1 in 200,000, and sodium bicarb, or 15 ml of 0.5 bubi or ruby may be used to initiate epidural anesthesia in lumbar region. Maintenance of desired level of epidural can be accomplished through intermittent or continuous dosing. The usual infusion rate is between 4 to 15 ml per hour. The wide range is usually dependent on the age, weight, extent of sensory or motor blockade desired in a particular patient, site of catheter insertion, and the type and dose of local anesthetic. Patient-controlled epidural analgesia, PCEA, most commonly with infusion of low concentration, low local anesthetic and opioid adjunct, are increasingly used for postoperative analgesia and laboring patients. Now, refer to my lecture 5 in perioperative pain management to learn more about local anesthetic dosing, toxicity, etc. Local anesthetic procedure produce reversible nerve blockade by blocking sodium channel through the nerve membrane. Again, I covered that in more details in lecture 5 in the perioperative pain management. When local anesthetic is injected into the epidural space, several things can occur. Most of the injected local anesthetic is absorbed in the venous blood, and a large part is retained in the epidural fatty tissue. The primary site of action of epidural administered local anesthetic are the ventral and dorsal nerve root that pass through the epidural space. So this table show you the most commonly used local anesthetic for epidural anesthesia, and it gives you the time of onset and the duration, whether it's plain or mixed with epinephrine. The shortest acting local anesthetic for neuroaxial blockade is the Tubechlor procaine. In the past, it was reported to be associated with adhesive arachnoiditis when a large volume were administered into the subarachnoid space. In addition, severe back pain is not uncommon when large volume is administered in the epidural space. Back pain following injection of large volume of 2-chlorprocaine can be caused by muscle spasm because it contains the preservative EDTA, which is a chelator of calcium. So large volume can chelate the calcium of the nearby muscle, which causes local muscle spasm. Therefore, in 1996, preservative-free 2-chlorprocaine has been available and not been associated with either neurotoxic effect or back pain. So make sure you're using a preservative-free 2-chlorprocaine when you are using it. Alkalinization of local anesthetic, which are marked in water-soluble ionized state, hasten onset by increasing the concentration of non-ionized form. More lipid-soluble local anesthetic is available to penetrate the neural sheath and nerve membrane. Combining short and long-acting drug for rapid onset and prolonged sensory nerve block has not been proven to be effective. Local anesthetic can be mixed with a variety of drugs, including opioid, clonidine, midazolam, ketamine. Time to repeat a dose, especially if you don't have the equipment for continuous infusion, depend on duration of the drug. Dose should be administered before the nerve block regress to the point the patient experiences pain, commonly referred as the time to two segment regression, which is defined as the time it takes for sensory nerve block to regress by 2 dermatome level. So when 2 segment regression has occurred, 1/3 to 1/2 of the initial loading dose can be safely administered. And this table show you roughly the timing and dose. Advantage of continuous infusion, therefore, you need to do that. Greater cardiovascular stability, fewer labor requirement, decreased incidence of tachyphylaxis, decreased frequency and severity of side effects, decreased referral speed, decreased risk of potential contamination, and the ability to achieve a steady state of analgesia. Again, combining local anesthetic with opioid may have a synergistic effect. The optimal duration of epidural analgesia has not been determined, but usually is 2 to 4 days post-surgically. Epidural opioid, very helpful analgesic, and they spare your sympathetic and motor blockade. In general, hydrophilic opioid like morphine and hydromorphone tend to have a slow onset and long duration On the other hand, lipophilic, like fentanyl and sulfentanyl, will have a quick onset and shorter duration. And you can use sulfentanyl in patient with opioid tolerance. And you can use morphine. Epidural morphine is about 5 to times the dose of intrathecal. So you can do 2 to 3 milligram of epidural morphine if you're doing a single bolus here. You can also use clonidine. However, the biggest side effect of clonidine is hypotension, bradycardia, and sedation. There is this newly available, recently approved, extended release epidural morphine, which is a deeper dose, which is believed that can last up to 48 hours after single injection. This table summarizes some of the doses for common medication. Now let's talk about special consideration in labor epidural. So when we spoke about anatomy and physiological changes, we kind of cover that you have more engorged epidural veins, you have more edematous ligamentum flavum up to 10 millimeter, and that can affect your sensation of loss of resistance. But what's important here for first stage of labor, you have to cover T10 to L1. For second stage of labor, T10 to L1 plus extend that to S2 to S4 to cover the vaginal and perineal innervation. Analgesia may be maintained with a continuous infusion or PCEA, which is even better if it's available. During delivery, the sacral dermatome may be blocked with 10 ml of bubi or lidocaine or Tubechlor procaine. However, if you have the epidural running for a few hours, most likely you will have the local anesthetic covering the sacral dermatome, and you don't need the top-up doses. Combined spinal epidural analgesia can be used, especially if rapid analgesia is required and the patient close to the second stage. The most used agent for obstetric epidural anesthesia are now we are talking if you want to convert it to if you have an urgency section, you want to convert it to epidural anesthesia. So you can use either 2% lidocaine with epi and sodium bicarb, or you can use 3% Tubechlor procaine. Adequate anesthesia is usually achieved in 15 to 25 minutes of local anesthetic solution administered in divided doses over 5 to 10 minutes. Tubechlor procaine provides rapid onset of a reliable block with minimal risk of systemic toxicity because of its extremely high rate of metabolism in maternal and fetal plasma. While the lidocaine can cross the placenta and reach the baby. Okay, let's see some troubleshooting for malfunctioning epidural, specifically for labor epidural here, but it can be also applicable for surgical epidural. So here is a nice table show you how to differentiate whether your catheter in the subcutaneous space or subdural space or intrathecal space or intravenous space. With the incidence here, speed of onset, and motor blockade. So obviously, you will have motor blockade only if you are subdural or intrathecal. However, you have an impressive motor blockade if you are intrathecal, depending on the dose. while you have minimal motor blockade with sympathetic sparing if you are subdural. Complication, especially if you are subdural, you can have high sensory blockade, but minimal motor blockade, no sympathetic blockade, and you can have Horner syndrome and patch block, and obviously a bunch of problems if you are intrathecal. Now, you are assessing the epidural, and you find out that you have low block or no block. So you can give 10 to 20 ml of local anesthetic. I would go with 2% lidocaine here because we want something quick and we want a short acting. I want to make a decision. Wait for 20 minutes and reassess, and if that's not working, so then replace the epidural. If we are missing a segment here, the first, make sure it's really a missing segment and you are not dealing with a unilateral blockade. And if it's unilateral, I'm going to talk about it in a second. If it's really a missing segment, then try to give a small dose of local anesthetic, again 2% lidocaine. Give fentanyl, that would be nice, and reassess after 20 minutes, and then make a decision whether you need your replacement or not. If you have a poor sacral coverage here, then again, if it's a labor epidural, suspect this patient, she's getting close to her second stage, and she's the head of the baby engaged, but appreciate the patient complaint, and the closest way to examine that area is to test the lateral aspect of the feet, which is covered by S1, so it's closer to the perineal area, and then give 10 to 20 ml with the patient in the sitting position, and recheck after 20 minutes. If it's still a problem, then you may need to reconsider placing the catheter at the lower level. If it's a unilateral block, first, what you need to do, so position the patient on a lateral position where the unblocked position down, and give a local anesthetic, about 10 ml, and see what will happen. If it does work, you can pull the catheter a little bit and give a local anesthetic again and see what will happen in 20 minutes. However, be careful, don't just keep giving local anesthetic, because what will happen if you have a plica mediana dorsalis, I covered that in the first lecture, this will keep going up and up, and you may end up having Horner syndrome. So if you troubleshoot it twice, you give total 20, you waited, you put the catheter, then still not working, you give fentanyl, still not working, then consider replacing the epidural. Side effect and complication. So it's important to distinguish between side effect and complication. And that's very important when you consult with the patient. Tell them what side effect, so if this happen, they don't think something wrong went, because you might have a perfect epidural and you still have hypertension, right? And this is the complication. So we'll go over each of one briefly. Let's start with hypertension. Defined as greater than 20% reduction in systolic, diastolic, or mean blood pressure. Risk factor: high thoracic block, obesity, concomitant general and neuroaxial anesthesia, hypovolemia, excessive intraoperative blood loss, and labor epidural. Clinical manifestation: the first sign is nausea. When the patient tells you, I'm nauseated, please jump in and do something. Give vasopressor and make sure you have the fluid open. Then lightheadedness, mental status changes, shortness of breath. This is a later manifestation. Optimally, the blood pressure should be maintained within 20% of the patient resting baseline. Prevention by administration of vasopressor, especially in labor epidural, most commonly ephedrine and phenylephrine. There are a bunch of studies there. Volume expansion, either as a preload or co-load. Uterine displacement, changing the patient position, and reducing the dose of intrathecal or epidural local anesthetic. Treatment: discontinue epidural, give volume, start vasopressors either as boluses or infusion. Use Trendelenburg position, ensure uterine displacement in labor epidural, elevate lower extremity. That's a very often forgotten technique if you have an emergency, mainly, with spinal anesthesia, and you are in low resource limiting. You don't have what you need. So even you can ask the surgeon to elevate the leg, give atropine, wrap up the leg, etc. Now, local anesthetic systemic toxicity, we'll go briefly over this. That usually happen from direct intravascular injection or unintentional epidural vein cannulation. Risk factor trauma, risk factor for epidural vein cannulation, trauma to the epidural vessel during a block initiation, multiple attempts, using stiff catheter and flexible catheter, engorge epidural vein like in pregnancy, and putting this in sitting position. Strategies to avoid epidural vein cannulation: placement in lateral position, use of flexible wired reinforced catheter, use of single versus multi orifice catheter, fluid pre-distension prior to threading the catheter with saline, limit depth of catheter insertion less than 5 centimeters. Dosing the epidural catheter in 3 to 5 ml incremented with frequent negative aspiration of blood and CSF is recommended to detect misplaced catheter. Clinical manifestation of LAST, again, I covered that on the fourth lecture, but here quickly, some CNS manifestation, cardiovascular manifestation, and then treatment. The mainstay of the treatment is using the lipid, 20% with a loading dose of 1.5 ml per kilogram, followed by 0.25 ml per kilogram per minute. Catheter disconnection. This is a controversial topic. You will see it. If you are covering the floor, you are on call. Nurse will call you. The primary team will call you, like, come to the bedside. You have a disconnected catheter. What are you going to do? So there is no consensus in this area, and there is no much studies have been done. However, I found this is helpful. This is a survey was conducted in 2010 in Scotland, and a decent number of anesthesiologists responded to the survey. 15% of them said they would reuse the epidural catheter after cleaning and cutting it. 44%, like very, very, very close, would opt to remove the catheter and cite a new epidural delivery system if clinically appropriate. Only 6% would reconnect having cleaned but not cut the catheter. So factor favoring removal of the epidural catheter, including unwitnessed or prolonged disconnection, and macroscopic contamination of the catheter or a bed linen. If the epidural was cited perioperatively or due for imminent withdrawal or providing suboptimal pain relief. Factor favoring reconnection of the epidural catheter are in the setting of severe respiratory disease, recent thoracotomy, laparotomy, and ongoing labor, difficult insertion, prior anticoagulation. And they also recommended clean it with Epidural wipe, just because there is no enough evidence at that time for the chlorhexidine. Then cut it up to 5 centimeters from is contaminated and reuse it. My personal opinion, again, check if you have an institution protocol, but that's again my personal opinion. It's a case-by-case condition. So if you have the above favoring factor and you don't have the above unfavoring factor, and in your bedside examination, the catheter doesn't look contaminated or potentially contaminated, the patient is not immunocompromised, the patient is not anticoagulated, the patient, I wouldn't, if I'm planning to remove it, I will make sure that the patient is not anticoagulated. But again, not immunocompromised, then I will clean it with Epidural and cut at least 5 centimeters from the contaminated end and reuse it. So again, it's a case by case. Arachidonitis. Arachidonitis is a rare disorder marked by inflammatory changes in the arachnoid matter. Fibrosis develop and adhesion form between the nerve root and the membrane that surround the brain, spinal cord, and caudal equine. In chronic adhesive cases, collagen deposits ultimately encapsulate the nerve root, creating nerve root atrophy as a result of an interruption to the blood supply. Clinical presentation: back pain that radiates to the lower extremity and increases on exertion, buttock pain, muscle spasm, decreases the range of motion of the trunk, sensory abnormality, motor weakness or paralysis below the level of injury that does not typically progress, urinary dysfunction, and the clinical presentation of arachidonitis is complex and may be delayed for several months. Diagnosis usually by myelography and CT scan or MRI, and prognosis: significant neurologic improvement is unlikely, unfortunately, with the current therapies, including the steroids, NSAIDs, and antibiotics, and defect may progress to permanent disability. Backache. Hakim and his colleague identified the following independent risk factor for persistent, more than 3 months, low back pain after non-obstetric surgery with epidural anesthesia or analgesia. 1, multiple attempt at epidural placement, higher BMI, surgery in lithotomy position, and surgical time exceed 2 hours and a half. Back pain after epidural blockade is usually self-limiting and should resolve within 7 to 10 days. Patients should be encouraged to refrain from bed rest and use NSAIDs or acetaminophen or heat, maybe provide a symptomatic relief. If pain persists, progress, or is out of proportion to what might be expected, other etiologies such as transient neurological syndrome, herniated disc, spinal stenosis, arachidonitis, sacroiliitis, etc. should be considered. In pregnant women who have received epidural analgesia for labor pain, provide compelling evidence that back pain is unrelated to neuroaxial technique. Post-dural punctural headache. The incidence is generally accepted to be below 1%, and up to 80% of the patient may experience post-dural punctural headache if they have accidental dural puncture, following accidental puncture. According to the International Headache Society, this is defined as headache developed within 5 days of lumbar puncture and usually accompanied by neck stiffness or subjective hearing loss, symptoms, and resolve spontaneously within 2 weeks or after effective treatment with epidural blood patch. A clinical presentation usually fronto-occipital headache, intensify when the head elevated, neck stiffness, neck and shoulder and arm pain, tinnitus, hearing loss, nausea, vomiting, dizziness, diplopia, blurry vision, and nystagmus. Risk factors: younger age, female gender, low body mass index, loss of resistance to air, pushing during second stage of labor, use of cutting needle, especially with spine, and use of large gauge needle. Management: usually we start with symptomatic relief with analgesics, pharmacological agents with vasoconstricting properties like caffeine, sumatriptan, and possibly corticotropin. Bed rest and aggressive fluid administration seems to have limited benefits. You may try a sphenopalatine ganglion block. There are a few case reports there. And definitive treatment is epidural blood patch, with preferably doing early rather than late. And prior to performing epidural blood patch, other causes of headache such as preeclampsia, eclampsia, meningitis, elevated ICP should be ruled out in laboring patients. Subdural injection. So that's your dura here, and that's your subarachnoid space. So what happened that you pierce through the dura, but you are not far enough, so that the hole seat on the dura and create this subdural spread. So the subdural space has been described as a potential space between normally closed adherent arachnoid matter and the overlying dura matter. Although it may represent a cleft along the dural border cell layer that results only from direct tissue damage, injection of a small dose of local anesthetic into the area can have profound hemodynamic and sympatholytic effect. Subdural injection is relatively rare occur, estimated less than 0.1%. Clinical manifestation, this is very important. So if you have a higher than expected sensory blockade with poor caudal spread and sacral spread, with a higher than anticipated level of motor blockade of variable density, that may help to distinguish it from the epidural. A speed of onset that more closely resemble epidural analgesia. Subdural injection commonly results in bilateral blockade, although unilateral or patchy nerve block can occur with more notable sensory and motor change in the upper extremities and inadequate analgesia in the lower extremity. A patient may develop Horner syndrome, facial or corneal anesthesia, dyspnea, hypertension also may develop. Treatment may require cardiovascular respiratory support, including the administration of IV fluid, vasopressor, possibly securing the airway. Total spinal anesthesia. Very rare, fortunately, 1 in 1,400. Causes typically by administering a large dose of local anesthetic into the subdural compartment and undetected migration of epidural catheter tip into the subarachnoid space. When one hole of the multi-orifice catheter is lodged in the subarachnoid space with translocation of local anesthetic through an accidental or an intentional dural breach after combined spinal epidural technique and after a failed epidural block is replaced with a spinal technique. Clinical presentation: ascending sensory and motor change develop rapidly followed by profound hypotension, bradycardia, dyspnea, and difficulty phonating and swallow. Unconsciousness and apnea may result from direct local anesthetic action on the brainstem, respiratory muscle paralysis, and cerebral hypoperfusion. Treatment may include airway support, administration of oxygen, hemodynamic support, IV fluid and pressors, sedation until the nerve block regress. Prevention, careful administration of local anesthetic in small divided doses with frequent aspiration and possibly the use of epidural test dose, which I recommend. Patients should be monitored during the top-up, during incremental dosing to attain surgical anesthesia, and while on PCEA. If you end up having intrathecal catheter after accidental urine puncture, then the catheter should be clearly labeled. Epidural abscesses. Again, rare. It's estimated 5% of epidural abscesses are associated with epidural procedure, but it's very rare after epidural analgesia. Bacteria gain access to the epidural space most likely through the homogeneous spread or contiguous spread. The source of access is not identified in the remainder of the cases. Staph aureus and MRSA account for most of the cases of the epidural abscesses. Predisposing factor including elderly, bacteremia, steroid injection, diabetes, like immunocompromised patient, right? Renal failure, adrenal insufficiency, chronic epidural catheter, cellulitis, prolonged urinary catheterization, so as abscesses, osteomyelitis, etc. Clinical presentation, the classic triad is back pain, fever, and neurological changes such as leg weakness, sensory defect. Patient may present with bladder dysfunction, sepsis, meningitis, paraplegia, quadriplegia, UTI, etc. Symptoms most commonly present within 7 days, but may be delayed for up to 60 days. Diagnosis by contrast MRI, treatment broad spectrum IV antibiotic with urgent surgical drainage and decompression. Mortality, unfortunately, is high, even morbidity. And on the other hand, epidural hematoma. Again, it's very rare, and risk factor, obviously, if you do this in anticoagulated or antiplatelet therapy patients, thrombocytopenia, traumatic needle, multiple attempt, etc. Clinical presentation, rapidly progressing sensory or motor deficits to devastating paraplegia and incontinence. Early signs include back pain and pressure, bowel and bladder incontinence, radicular pain, worsening lower extremity neurological deficit. The onset of symptoms usually within 12 hours to 2 days of initiating of the neuroaxial blockade or removing the epidural catheter. Diagnosed by MRI, treatment by surgical decompression, urgent surgical decompression within a maximum 8 hours. And if you have underlying coagulation or platelet problem, start to correct that. Meningitis, bacterial meningitis following epidural anesthesia or analgesia, also rare. Microorganism can be transmitted via syringes, catheter, needles, effusion, tubing, etc. Most cases appear to be caused by contamination on the puncture site by organism from the nasal or oropharyngeal of the healthcare provider. Risk factors include breach in the aseptic technique, reinsertion of the stylus that has been exposed to air, difficulty performing neuroaxial, multiple attempts, etc. Clinical presentation, fever, mental status change, lethargy, headache, knuckle rigidity, nausea, vomiting, backache, photophobia, seizure, Kerning sign, Babinski sign. And symptoms usually present within 6 to 36 hours after procedure. Diagnosis, confirmed by CSF analysis and culture. Most common pathogen is Streptococcus salivarius, followed by Viridans streptococci, aureus, Pseudomonas, etc. Treatment start by immediate empiric wide-spectrum antibiotic and tailor that down. Spinal cord and nerve injury. Neural deficit can be caused by direct trauma to a spinal cord or spinal nerve injury or ischemia or hematoma, but they're, again, fortunately, extremely rare. And most peripheral neuropathy associated with neuroaxial technique resolve spontaneously. Those most that become permanent are usually limited to persistent paresthesia and limited motor weakness. Cauda equina syndrome. Rare state of neurological compromise due to lumbosacral root compression, causes trauma, infection, lithotomy position, ischemic compression by hematoma, abscesses, tumor, prolonged prolapsed disc, spondylolisthesis, etc. Presentation, bowel and bladder dysfunction, low back pain, perineal sensory loss, and other patchy sensory deficits, unilateral or bilateral sciatica, or lower extremity motor weakness. Risk factor, continuous spinal infusion with micropore catheters, accidental intrathecal injection of large doses of local anesthetic. And this is why the FDA removed the small bore continuous spinal catheter from the market early in 1990s. Treatment, high-dose corticosteroids, surgical decompression, depending on the cause, treating the underlying cause, antibiotic, for example. Anterior spinal artery syndrome occur most commonly in patients with vascular disease and concomitant decreased spinal blood flow due to obstruction, compression, or hypotension. Most common neurological complication after abdominal aortic surgery and rarely can occur after thoracic spine surgery. Risk factor, massive blood loss, persistent hypertension, and clinical presentation, immediate painless paraplegia and loss of lower extremity sensory function. Notice that proprioception and vibration are spared. Cardiac arrest, again, it's very rare, and causes include last myocardial ischemia and sympathetic significant sympathetic block. Minimize the risk here. Adequate preload, co-load, early use of vagolytic drug and pressors. These are some references and suggested reading. Thank you so much for bearing with me for this long lecture, and please don't forget to subscribe.